I'm Nimesh Patel from Mass Eye Near and Boston Children's Hospital. We did a study looking at geographic atrophy and visual acuity outcomes in patients with geographic atrophy with and without concurrent neovascular AMD. So the reason we did this study was really to assess a group of patients that wasn't assessed in the clinical trial and to get more data because the clinical trials cannot gather this much information. We use the Vestrum database, which characterizes patients in a group of different practices, AI and OCT to match them based on certain characteristics. Some of them include GA lesion size, as well as distance to fovea and subfoveal involvement. And what we were able to do is then make these groups that were really well matched based on these characteristics. One for GA, which was pegcetacoplan versus untreated, and one for GA and concurrent neovascular AMD that was pegcetacoplan plus anti-VEGF versus anti-VEGF alone. And what we found was really interesting. There was a greater proportion of patients in the pegcetacoplan groups that had better visual acuity or slower visual acuity decline. And that was most pronounced in the combination therapy group with the anti-VEGF treatment as well. And then when we cut it by patients who lost 15 letters or more, it was actually statistically significant at 6 months, 12 months, and 18 months for both geographic atrophy and geographic atrophy plus neovascular AMD. And we were able to find that this is the first study to show a visual acuity benefit in these patients. And this is kind of a revolutionary study for that reason. So the AI, what we used it for was really to analyze the OCTs at the begin with to match the groups. So one of the challenges is when you do these retrospective studies, it's very hard to balance the groups together because there's a lot of confounding factors. So we used AI to analyze the OCTs because it would take forever to hand draw these out. And so we were able to measure the size of the lesions and some of the other characteristics, as well as age and things like that, to match them together and basically make essentially a simulated controlled trial where we had a treated group and an untreated group, and even though it was retrospective and not prospective data. You know, the amount of person hours it would take is probably on the order of thousands and thousands. And I've been using more AI myself going forward, and it's going to be more and more a part of what we do for research. Even the propensity score matching is probably going to be with AI in the future, the statistical analyses, and it allows us to leverage these very big data sets that wouldn't otherwise be able to be characterized in a shorter amount of time. The initial trials were really looking at geographic atrophy alone. And when we did a practice pattern study at this meeting last year, we were really surprised to find out that people were using this medication. 25% of all uses were in patients with concurrent neovascular AMD, which was not the initial design of the study or the design of the medication, but we were finding that geographic atrophy was happening in this group, and that's where people were using it a lot as well. So it was really important to look at those patients and see if it does work. And it does seem that it does work not just for geographic atrophy alone, but may actually even work even better in this concurrent group with neovascular AMD. This is a big change. What we're finding, and I've even found this in my own patients looking back, we weren't really monitoring the geographic atrophy in those patients even to begin with. We were just saying, okay, you have neovascular AMD, these are the treatments, and we're looking for fluid. Now we're looking at geographic atrophy on the OCTs, and some of these patients I've actually seen now that I've been practicing for 6 years, they say, oh, I'm losing a little bit of vision, and you go back and you look at the OCTs, they've been losing vision from geographic atrophy this whole time. So it really offers a potential serious vision benefit for these patients that were otherwise losing vision. Even with the treatments for wet AMD, they're still losing vision during the atrophy. So I think if everybody looks in their own patients, they will find many of these that could potentially benefit. I think what's going to happen is we've hit a whole new era where not just anti-VEGF injections, anti-complement are going to be a big part of the clinical practice. What we're going to have to do is have to figure out how we're going to integrate these therapies together. One point I would make is that a lot of the patients who require both, they usually don't require a lot of anti-VEGF. They've usually gone to more of an atrophic phase than an active phase. And so it's not like we're really having to treat these patients every 4 weeks with both medications. I think oftentimes these patients are on Q8 or Q12 week anti-VEGF, and that we could use geographic atrophy treatments Q8 weeks and therefore not using a massive injection burden. But there will be some challenges in figuring out how to schedule these patients, but overall likely to be benefiting them in the long run until we have something else. The initial thought is that when we looked at practice patterns, most of the people were treating patients with moderate visual acuity loss and bilateral disease. However, we're finding, just like with any progressive chronic condition, earlier treatment is probably the way to go, even if they don't already have vision loss. Similar to things like diabetes, high blood pressure, we're starting treatments earlier and earlier and earlier, and I think it's going to be the same with geographic atrophy. So it's going to be extremely important for comprehensive ophthalmologists, optometrists to recognize GA, even if it's not in the center and even if it's not causing vision loss, and refer those patients because they actually may be the ones who are going to benefit the most. The other point I make about that is some of those patients are on the younger side. So as we talk about life expectancy and the rest of medical care improving, if you have a small amount of GA and you're 75, the thought might have been, well, it may not really affect your vision in your lifetime, but that's not the case anymore. These patients are living to 85, 90, 95. And so the benefit that we might be able to get is actually upfront. So earlier treatment is likely to be better. I think if it was my eye and I had bilateral GA, I would probably at least opt for treatment in one eye, because once you lose the vision from GA or once the GA progresses, currently with our modern technology, we still don't have any way to reverse the vision loss. So you have to think about getting in there before you lose the vision loss, just like glaucoma, just like everything else.